Hi guys, my name is Jim, and my colleagues Vanessa, Chris, and Tiantan will be evaluating a study surrounding the cost effectiveness of TYRX absorbable antibacterial envelope for prevention of cardiovascular implantable electronic device infections. The title, although long, captures a general concept of what the article is about. It tells us what the intervention is and the type of analysis being conducted. In this case, it's a cost-efficacy analysis. What isn't mentioned, though, are the specific outcomes involved and the specific population involved. However, we can infer from the title that the population involved are those with cardiovascular implantable devices.
As suggested by the title, the paper clearly states the objective in its introductory paragraph and abstract. The objective, which is to describe a cost-effectiveness model developed to assess the cost implications and health outcomes associated with the TYRX absorbable antibacterial envelopes versus current standard of care in prevention of infection post-cardiac implantable electronic device implantation from the NHS perspective. This covers the specific method of outcome analysis as well as the targeted intervention.
Currently, there are little or no established approaches to reducing CIED infections apart from antibiotic prophylaxis. Antibiotic prophylaxis is considered to be the standard of care and was used as the comparator in the study. Both groups were assumed to receive equivalent antibiotic prophylaxis, meaning that the difference in effectiveness is due to the device alone and not missing the antibiotic prophylaxis. Comparing against the standard of care is a very strong alternative given the lack of other interventions in this field.
The article stated a basic comprehensive description of the alternatives given, where the intervention was compared against no intervention or not being given TYRX, or in other words, given the standard of care for patients undergoing de novo or replacement implantation as listed. The article defines standard of care therapy as one course of preoperative antibiotic prophylaxis only.
The perspective of the study was directly addressed in a statement in the abstract of the article. Quote, the model was parameterized for a UK National Health Service perspective, end quote. The study was also funded by Medtronic, a medical device company. We can also see the article in the perspective of the funder as well, since they have a stake in proving that there is a difference between the envelope versus the standard of care.
The study has been stated to be a cost-effectiveness analysis, a form of economic analysis that compares the relative costs and outcomes of different courses of action. In this study, the outcomes were measured in euros per quality gain patient.
Patients in the TYRX arm were assumed to receive the envelope at a one-time cost of £719, which is the price in 2015 for the device. Patients in both arms were assumed to receive the equivalent course of prophylactic antibiotics based on the results of a study conducted by Sharif et al. And the NHS price list. The total number of cardiac ward bed days and ICU bed days, as well as the adjusted cost per day, was obtained from Ashan et al. And adjusted to 2015 costs. Cost of device extraction and replacement was taken from UK tariffs. Given that this study was conducted from the perspective of the UK National Health Service, we believe that the relevant costs were appropriately determined in this study.
One of the most important outcomes would be seen as the reduction in postoperative infection risk being decreased by 2.9%. TYRX was also seen to have a reduced cost versus ICD and CRT-D implantation, while having an increased cost for the other two implantation types. These 2 points is the 2 points of cost-effectiveness analysis that are desired, having a decrease in cost while having an increase in benefit, which in this case is a reduced infection risk. In addition, patients with TYRX were seen to have a slight increased survival of 2.8%. There was a very large decreased probability of device extraction, which is one of the major problems seen in implanted devices, and hospitalization. A smaller but still fair decrease in mortality was also seen in the intervention. All of the outcomes seen here are extremely important to physicians, showing us a very prominent increased benefit to the patient if given TYRX. From the article, it was stated that 22 patients would need to be treated with TYRX to avoid 1 hospitalization, and 37 to avoid a device explantation. This statement shows the number needed to treat and is targeted towards clinicians to allow a quicker way to show them how beneficial TYRX would be for patients. In this case, the low number of patients needed to treat quickly allows physicians to declare that TYRX would be effective. The table from the study shows TYRX being dominant against ICD and CRTD, giving the incremental cost on the side to show a compared decreased cost for TYRX against the 4 types of devices. This table shows the infection risk percentage at which TYRX was cost-effective in comparison to standard of care for the 4 different types of implantation devices. Overall, TYRX was seen to dominate standard of care at baseline probabilities of infections more than 7.69% for all device types. At a willingness to pay threshold of £30,000, it was considered cost-effective for any device if the baseline probability of infection was greater than 1.95%. Since TYRX would mainly be used in high-risk patients who would easily reach these percentages, the table shows that TYRX would be an effective option for its indicated purpose. The red shows the upper range of percentages that would need to be reached for TYRX to be cost-effective, and the green shows the lower range. As you can see, as stated in the outcomes, TYRX was seen to do best against CRTD and ICD, and less so against CRTP and IPG. The study was done in a 12-month time period. As post-surgery infections happen within weeks after surgery, it was more than enough time to follow up with the patient. They used a decision tree analysis to find the best time period, where they used probability to essentially ensure that any differences in lifetime costs and benefits due to mortality differences between treatments were captured. In addition, it also allowed them to ensure the infection was indeed due to surgery rather than other factors.
During the time of the study, no adjusting and discounting were necessary as the study was only designed to last 1 year. However, since the article was published in 2017, the prices analyzed were adjusted accordingly.
Whenever estimates are used, there is a possibility that these estimates may not be precise. These estimates may be referred to as assumptions. The assumptions made in this study are as follows. In regards to infection risk, the relative risk would apply consistently across all risk groups, with a difference in infection rates driven only by the difference in the baseline risk, the probability of infection with the standard of care. As such, the relative risk was determined by pooling the total population's number experiencing an infection across all studies for standard of care and independently for TYRX. Other assumptions included the proportion of patients experiencing a successful or partial extraction and device replacement following infection, baseline infection rates across all device types, use of antibiotics in those receiving TYRX, impact of infection on the utility of the patient. These assumptions were explicitly stated and reasonable.
TYRX remained dominant in a number of scenarios using a 12-month time horizon. In addition, no ICERs in excess of £30,000 per quality-adjusted life year gained were generated in the scenario analyses when using a lifetime horizon. However, the exception to this was the choice for baseline infection rate. Alternate sources, which are listed below in the table in the highlighted red box, indicated some instances where TYRX was the dominant or cost-saving option, and others where the ICER increased beyond £20,000 per quality-adjusted life year gain. Analyses indicated that TYRX was dominant standard of care at baseline probabilities of infection exceeding 7.69% for all device types, and TYRX would be considered cost-effective at a willingness to pay threshold of £30,000 when used in any device at a baseline probability of infection exceeding 1.95%.
There are many study limitations that were stated in the article. First, there was an absence of device-specific data for interaction rates and mortality rates, which in turn may have underestimated the impact of their intervention. Selection bias could have also been seen as they were using retrospective databases to obtain specific types of patients. With that, it would limit the generalizability of the results. In addition to that, they also had a decreased external validity, which they used a very specific population in small sample sizes, which may be beneficial for that specific population, but makes it very difficult to extrapolate or assume the same benefits for other related groups. Lastly, they stated there was no data available in some costs and outcome values, in which case they made broad assumptions for their study.
It's difficult to extrapolate the data beyond the scope of the study since there's limited data surrounding envelope use beyond the 1-year scope, as well as in general. The author stated that the current model is informed by data reported in observational studies due to a lack of prospective RCTs in the disease area. Right now, there are 2 ongoing studies, the RAPID trial and the envelope trial, which may provide the necessary data to extrapolate upon completion.
In summary of our interpretation of the study, the results were presented in an unbiased way. The conclusions were not overstated or over-extrapolated in the results section. A range of scenarios and sensitivity analysis were undertaken, and the model was shown to be generally robust to all the changes. It made sure to note differences in the alternative sources in the calculation of cost effectiveness. For example, some instances where the TYRX was cost saving, the dominant option, while others where the ICER was increased, was beyond 20,000 euros per quality gains. There were also appropriate alternatives, as there are currently little to no established approaches to reducing CIED infections with antibiotic prophylaxis considered to be the standard of care. Comparing against the standard of care was the strongest alternative. Taking that into account, the article made sure to outline that fact in the discussion. As for the results of the study being believable, yes, the results were well discussed and the limitations properly addressed. The conclusion was well supported and will add greater significance to the intervention study.
The authors of the study concluded that at cost-effectiveness thresholds of between 20,000 to 30,000 per quality adjusted life year, which were pulled from UK device-related reimbursement decisions, TYRX represents good value for money. And at a 12-month time horizon, TYRX was less costly and more effective than standard of care in patients with CRT-D or ICD devices. However, the current model lacks device-specific data for infection rates and mortality rates. Lacking this critical data could mean that this model is very inaccurate after the clinical trials involving these devices are completed. However, given the increasing number of these procedures that could lead to an increasing infection rate and further burden to the patient and health system resources, this study findings show that TYRX is a cost-effective treatment for reducing post-surgical infection risks when used in conjunction with all CIEDs.